So hello everybody. As I've just been very well introduced, I'm Paul. I do my PhD at Imperial College London, where I work on safety assessment of my PhD is on overall clinical decision support systems, but I focus as a case study on a clinical decision support system that was developed by both my supervisors for sepsis treatment in the intensive care unit. And today I would like to share with you the first steps we've done towards assessing the safety of the system and how iterative the approach that we have adopted is. So before all, clinical decision support systems can sound like a mouthful and things are like, what are they really? And they don't need to be very fancy things, as in we've all seen the bedside monitors that clinical teams use to make better decisions about patients. Could be those mobile echo machines that you see around or the good old lab notes. It's essentially anything that can help clinical teams or other people taking decisions about patients. Now, how can AI help in this? Well, in many ways. AI can help diagnosing what a disease is. It can help predict when a disease will strike with the system that predicts the onset of sepsis in the intensive care unit. Or it can help choosing what to do with a given patient and recommend treatment. And it's on this specific area of AI for medical practices that I'm working on and that I will share with you experience today. So recommendation systems, I'm sure you've all come across them at some point. We all have a Netflix subscription or all went on YouTube at some point, and we've had this recommended for you line on the top. And what happens is those companies, they just have loads of usage data about what have people looked at. They send this to an algorithm in order to maximize the amount of time users spend on their platform looking at shows. Well, if you replace 2 or 3 of those elements and put this in a slightly different context, well, you're now in an ICU room where you have patient data that you can send into an algorithm. And this algorithm can recommend decisions to improve patient outcome, whether this is survivability, length of ICU stay, or any outcome that you may think about. Now, huge tech companies can do this because they have a lot of data. And I have to admit that because we're working with intensive care units, where people are plugged into sensors almost 24/7, having a lot of their vital signs recorded and lab results put into computer systems. And thanks to the fantastic efforts of lots of hospitals around the world during the last decade, we now have fantastic databases with, in our case, intensive care unit data, recording the data from hundreds of intensive care units and millions of patient stays that allow us to develop those systems. Now, when it comes to clinical decision support systems, the presence of all these data sets has really helped the research community. However, a recent review paper, of which I've extracted this figure, shows that there is still an important research bedside gap. So if you look at this chart, on the top you have research, on the bottom you have bedside. On the x-axis you have time, and the bigger the circle, the more papers were published on clinical decision support systems at this point in time. And what you can see is that we have had 2 barriers. First one is a modeling barrier, where advances in AI around 2010 has allowed researchers to build better and better models. But the second one is bringing all those fantastic research works to the bedside. And this is not done these days, in particular because of concerns for patient safety. And this is where my PhD project and today's presentation fits in. The system I work on a daily basis on my PhD was developed by my supervisors to help treat sepsis. So for those of you who are not that familiar with this condition, sepsis is a general infection with organ failure. And it's essentially an infectious agent, let's say to simplify on this slide, a bacteria, starts spreading through the blood and attacks organs one by one, leading to, if not treated, multiple organ failure and eventually potential patient death. The way this is being treated is patients are given antibiotics to kill the bacteria and support to different of their organ functions. Now, in terms of figures, sepsis in 2017 has been estimated to affect around 50 million people worldwide, unfortunately killing 1/5 of them, and is costing, or being estimated to cost, around £50 billion a year to the NHS. So even improving a slightly little bit the outcome of sepsis could have a tremendous impact. the treatment of sepsis, so there's the antibiotics that kill the infectious agent, but then organ function is being supplied to the patient. If their lungs have problems, they are put into mechanical ventilators. If the kidneys have problems, you have dialysis machines. If the heart and veins start to struggle, patients are given IV fluids and vasopressors. And it's on this exact bit of the treatment that the AI system that we're working on is focusing. AI, to give you a little bit of a sense of what those things are, IV fluids are essentially salty water that you add into the blood to increase the volume in there, and vasopressors are compressing the veins to help, once again, maintain the proper blood pressure in the system. So the system that we're working with, called the AI Clinician, works using this AI technology called reinforcement learning. While this may sound odd at first, reinforcement learning is about an agent that interacts with an environment, takes actions in order to maximize the reward signal that it will get. I'm sure you've all heard of reinforcement learning through the breakthroughs of AI that beated human in chess. And those AIs, what they did is they interacted with a chessboard, the environment, to move pieces, take actions, and maximize the reward that they get by winning as many games as possible. Well, if you translate this in the clinical setup, to have the setup of the AI clinician, the algorithm interacts with a patient, recommends drug doses in order to optimize, in our case, long-term survivability of the patient. And this is done all in a sequential manner, right? There is no ground truth in chess as to which move should be played at this point in time to win the game with the highest likelihood. And it's the same thing for sepsis. The amount of confounders in there makes it impossible to determine at each point in time what is the exact thing to do. And this is all a sequential decision-making problem where one decision leads to all potential futures, and you try to take all of them in order to maximize the outcome that you will have at the end, and for the algorithm to maximize its reward. Now the question is, given that we have such a complex system, how do we assess the safety of it? And I'm always a big believer in the fact that research is standing on the shoulders of giants, and if you want to build something, when you might as well look at what people did beforehand, or what experts in that domain did. And here I'm going to give you an example which we've discussed quite a lot with our colleagues here at the University of York when working on this project, about a UAV landing system which essentially shows a safety case or a safety diagram about such a system. And I think there's quite a lot to learn about this. While the diagram may look a bit daunting, looking at the elements one after the other, I think helps understanding it more clearly. So here, this is about a a taxiing system, so something that drives a little plane on the ground. And this diagram puts the plane to a given context. In this case, it's been rainy that day, the visibility is not that good. On the left, it lists everything that could go wrong. For example, the AI system that's driving this plane could misalign it with the wrong line on the road that it's supposed to follow, leading to bringing the plane out of the road and crashing the UAV. Now, there are different barriers that are put in place before the plane actually gets to drive in the design of the system, and there also are barriers that are put in place afterwards in case things are to go wrong while the plane is driving. There's still a human operator who's there to pull the brake. And what's interesting to look at is, there's the structure of this diagram, but also each of those barriers, they have little strength scores underneath them, showing if one of the bad events on the left-hand side, hazardous events, was to happen, how likely is each of the barriers to stop it? And I think it would be interesting to have the same thing for our AI clinician for sepsis treatment. But beforehand, while in the case of the plane driving on the ground, it's easy to identify what can go wrong. This question is not as obvious for sepsis treatment. You can see this type of diagram in physiology, where here we're looking at either one of the two drugs that is dealt with by the AI clinician, in this case IV fluids. And you can imagine that for somebody who's very hypovolemic, so who lacks of fluids a lot in their body, it's not a good thing to give them no fluids. And similarly, for somebody who's already almost drowning, giving them more fluids is not a good thing. We know that the ideal treatment is somewhere in the middle. We know that this area is probably not ideal. However, we know that being extreme in our doses, and in some extreme cases, is for sure very dangerous for the patient, which led us to identifying different scenarios with both the vasopressors and the fluids. If you underdose and overdose them to patients who need them or who have had too many of them, it will lead to poor outcome for the patients, and we know this for sure. So Underdosing, overdosing, we've turned this into this little diagram, just very similarly to the UAV we've seen beforehand. And this leads to something looking like this, right? The system would recommend a dose that is hazardous. This would be shown to the clinician and then potentially administered to the patient. And think about it, what are the barriers that we can put in place to prevent this from happening? First, there would be a smarter training of the system before the system gets deployed. And then once the system is deployed, of course, we're not building a sort of magic cupboard in which we would put the patients and they would be healed like that. The system will work hand in hand with doctors, and we believe a lot in that. So this collaboration will lead to doctors being able to overlook the system, and if something looks very odd, they'll be able to stop it. However, in the literature, we don't have any information about the strength of those barriers. So we went on and tried to get an estimate for those. For the first one, it's all about training the system, and we fortunately have a lot of retrospective data on which we can assess this. So as a reminder, our 4 hazardous scenarios, underdosing and overdosing, both of the 2 drugs, leads to 4 scenarios. And we've studied those on retrospective data. So this is a diagram that shows for one of our 4 scenarios, in this case, low blood pressure patients that received no vasopressors, on the retrospective data that we have from the MIMIC database, an American intensive care database. And what you can see, well, the way this reads, rather, is for a given threshold of blood pressures, which you can see on the x-axis. X-axis is like blood pressures. You can see the proportion of human and safe decisions that were made in the database, the proportion of AI and safe decisions, and at the bottom, the p-value for the statistical significance of those. And we've looked at this for this scenario, but we've looked at all the 4 scenarios in the end. And to make the readability of this slide a bit better, let me highlight to you all the scenarios in which we've had positive evidence in the fact that the AI was taking less unsafe recommendations than human doctors did on the retrospective data. This was statistically significant in 3 out of the 4 scenarios. Now, this is one thing, but then comes in the question of, can we actually make the AI better, slightly tweak it, so that it becomes aware that those decisions are not things that should be taken. And the way the original AI system works is it only gets reward at the end, right? I told you the reinforcement learning agents, what they want is to optimize the reward that they will get, and it's the only awareness, knowledge that they will have about the world around them. And in the first iteration of the system, this was only about mortality in the end. Has the patient survived or not? Which is actually the true reward that you want to optimize, but you can also add in little penalties in the middle when unsafe things are being done. And so we added this to a second system that we retrained with the same data in the exact same way. Only difference is now we've introduced this little penalty in the middle saying you should not take those decisions. And implementing this, well, you can see on this bar plot the proportion of unsafe decisions or hazardous decisions that are taken by human and on retrospective data, original AI in light blue and the retrained AI in yellow. And in all of the 4 scenarios, we've decreased the number of unsafe decisions that have been taken, while you can see on this plot not harming the performance of the AI too much. And so now that we have retrained the system for it to be slightly safer while not harming its performance too much, we can go back to this diagram and we suddenly have an estimate of this barrier strength based on our retrospective data. We now know that in 88% of the cases, the AI won't recommend anything that's problematic. Now the question is, how likely is it that if the AI on the 10% of the databases where the cases could go wrong, and out of those 10%, the 10% that the AI will miss and recommend something that could be hazardous, how likely is it that human clinicians working around the AI will spot this? And this is something we're currently working on a simulation experiment, trying to involve general clinical teams and interact with the AI system. So as a discussion on safety assessment for this type of system, one thing we've really realized is the importance of the iterative aspect of things. As in, when you assess the safety of a system, we have realized going through it that there are things you don't think about at the start of things, and therefore you need to go back and redesign your system. Hence the importance of the approach that we've brought here by reshaping and introducing intermediate rewards is here we've realized underdosing and overdosing is maybe not ideal, but maybe there's something else that is not ideal either. And the beauty of what we've introduced is we just had to add a little penalty for the system and retrain it in order to have a system that's more robust towards those new rules. And also, setting rules and using human knowledge for safety assessment is a good thing. It allows us to go a long way, but it's definitely not what's going to solve the entire problem because, well, the reason why we are building AIs to solve this specific problem of cardiovascular management of sepsis is because we don't know what the safest treatment is. If we knew this, we would know what is the ideal thing to do with each and every patient. So, yeah, rule-based cannot carry us all the way. In this project, we've also had thoughts around the autonomy of systems and how different levels of autonomy carry different ethical implications, which I also think we're interested in. And if you want to have a read, just go check this paper. I won't have the time today to delve with more details into this. But as a conclusion, my PhD has started on the observation that there is still a large gap between research and bedside, partly due to concerns for patient safety. We have seen the importance of having an iterative approach to things, and the method that we've introduced here hopefully goes in this direction and allows flexibility. And there are a lot more topics around bringing AI to the bedside that I've not had the chance to talk about today, but are, to my eyes, as exciting as what I've presented, around having systems that are uncertainty aware, explainable, and also studying how those systems will be interacted with in the real world. As a conclusion, I would like to thank the whole team that worked alongside me on this project. And this is the conclusion to my talk. I'm very happy to take any questions. Here are the references for people who are curious.
Thank you very much, Paul. That was quite very interesting. Anybody in the audience got any questions? Richard?
Thanks very much. Thank you, Paul. That was really interesting. I guess my question is a general question really around when does AI become acceptably safe? So is it at the point where it's safer than a human? So these results are encouraging that would suggest that AI detection of sepsis is more efficient than a human, based on the graphs you showed us. So is it as simple as saying, okay, AI is now better than human beings at doing this, so we can implement it, or is there a threshold by which you have to pass in order for it to become, implemented in life? That's a general question really about all of this, I guess. But is there any sort of discussions around that just now? Any sort of intention?
Yeah, there are loads of discussion around that. And you say it's a very general question, but it's also a very important one. So the challenges that we have essentially with this type of system is while an AI that learns with reinforcement learning to play chess, you can have it play millions of chess games in a simulator. We don't have a good enough simulator of the patient body to have an accurate estimate of what the AI performance would be if tomorrow we were to launch this in a hospital. Those are only statistical estimates that we have from retrospective data, which is there will be a difference between the performance that is shown from those methods called off-policy policy evaluation compared to what will happen in the real world. And this is why we're taking this transition very carefully, observing the AI at every step. And I think it's very interesting because we saw in the previous talk this deployment approach where you go in hospitals, you first connect to the live data, then you look at the algorithm performing without implementing this in the actual practice, without the actual practice knowing that the algorithm is there. And I found it very interesting to see it on the previous talk because we're doing the exact same thing these days. And now when it comes to the safety of the algorithm, I think there is a little paradox here that has puzzled me since the beginning of my PhD, because I really believe that our doctors are doing the best that they can to cure patients. And if they knew that there was a better way to treat patients, then they would do it. And if we think that an AI can help in adopting better treatment strategies, then it means that we will have to, at some point, show doctors recommendations that are different to them, because if we want different outcomes, we'll have to do things differently, but in a way that they will still want to do it. It will seem reasonable to them. So it will be very interesting to me to see what will be the interaction between ICU doctors and this AI once we will come to points where the recommendations or the decisions might be different.
Thanks very much for that. I guess it's all about remembering it's a support tool. It's not a replacement. It's to help clinicians. It's not to replace anyone.
Absolutely, yeah. This tool is really seen as a support tool, and as I said, really not as a magic cupboard in which you push patient and they heal by themselves.
Okay, thank you.
Yeah, Paul, thank you for that presentation. I'm just interested whether internationally there are jurisdictions where there's a greater risk appetite to, roll this out on the front line and to address that research bedside gap that you talk about. Because I know the UK tried to position themselves as a place where innovative technologies can be accelerated onto the front line. But when you balance that against the kind of risk appetite that the UK tends to have, are there other jurisdictions where we can perhaps progress this kind of work quicker?
Yeah, so to be perfectly transparent with you, I'm not as much at ease with the regulatory questions as much as the AI questions. But what I've seen from talking with a few colleagues in the United States, for example, is that they also are at a point where they start to want to deploy such systems. But the fact that those technologies are very novel, I don't think any regulation is really ready for those or completely mature around it. I think what I've heard from my supervisors is one of the big chances we have in the UK is that the regulatory bodies seem to be receptive, at least to chat around the systems, exchange on what they are, and involve all the stakeholders in the design of the regulatory pathways. So I think we are rather well placed.
Hi. Thanks for that. I'm Shakir, NHS Digital. Have you got any thoughts on if we should explicitly, and again, this might not be exactly your area, so I appreciate that, but with these type of systems, what's your opinion on if we have sort of some guidelines or recommendations going forward where you explicitly build in counterfactuals or explainable AI techniques as a must, potentially to improve the risk profile?
Yeah, so that's a very good question. And actually, in this team, just next to me is Miura Nagendran, a clinical fellow and clinical PhD in our lab, who's spending his PhD on those questions of explainable AI. What I've noticed working alongside him is having an explanation that is fulfilling is very challenging, because you don't want to post hoc explain a system. In the meantime, you want something that is approachable for clinicians to understand properly. You want to be able to speak a very similar language to them. And from him chatting to ICU colleagues, very recently there's been this ICU conference called State of the Art, where he presented the system to different colleagues, and they were like, well, ideally we would like fully fledged clinical explanations and reasoning as to why this treatment is being acted on. And those are things that are very hard to generate. My belief is that at first, the first bit of explainability that makes sense mathematically speaking and that is understood by most people is uncertainty. So I think that the first step towards an explainable system like this one, or at least for a treatment recommendation system like this one, is going to have a system that, on top of the recommendation that it provides, also provides uncertainty around this recommendation. I'm making it for you because I had a lot of evidence backing it up, and I'm confident that this is a good one. Or this recommendation, I'm showing it to you, but I'm really showing it to you because you've asked me for a number. I don't have a lot of data backing this up.
Thanks, Paul. I'm Mona Johnson from NHS Digital. So thank you for such an accessible talk, because I was a bit worried that I wasn't going to be able to follow it as a clinician, but you made it really accessible. Thank you. And the question that I had was really thinking about how how we kind of, as humans, work alongside AI tools. And as a GP, although I'll take myself out of that context, because I think there are specific use cases where it's easier, maybe in imaging, and as you've discussed in areas like vasopressors and IVs, I actually think it's more accessible. But how do we move between having oversight of the product, which is what a lot of the public and I think the sentiment amongst clinicians is, to a place where we actually trust the thing is going to do the thing that it's meant to do, but we're aware of when to pump the brakes, if you like, when the plane isn't taxiing to its right destination. And just to pick up on what Richard said, sorry, this is a long question that's not ending. We do this with clinicians anyway, don't we? When we're training doctors and nurses, often the process of supervision is about talking through in the abstract to moving to a place where people practice independently. And I wonder if there's an analogy there as well. So pick any one of those to answer.
No, well, I would say those technologies for the most part are rather novel. I'm already very pleased to see the education that we can see amongst doctors on those new coming technologies. And my cousins are studying medicine back in France and seeing that they have sometimes modules here and there making them aware of what at least computer systems are and how AI works and may help them in their work in the future is already a fantastic effort. Now, I think that what you said about having trust in the systems and understanding when to pull the brake will be a question of seeing those systems make their, you say in English, proof of arms, as in see them behave for a little bit, understand where they work properly, where they work less, and becoming more or less used to them. Just the same way your, I don't know, software on a computer, you may know that from time to time it may crash. And we've known this just because we've used software and computers for quite a bit of time. And at the beginning, it's all about monitoring those systems very carefully. And then once we understand them very properly, I think there's a lot of effort around communication, making sure that everybody is involved, everybody understands what's going on, how those systems work. And by understanding how a system works, what it has been built on and why it works, I think that's the best way for people to, or for medical professionals to then be able to use those systems as optimally as possible. Thank you.